What are some misconceptions about migraine you wish people understood? For someone listening who feels dismissed, unheard, or stuck, no answers, what would you want them to know about advocating for themselves and continuing to search for the right care team? How important is it for a clinician just to step back and look at the entire clinical picture like you do, instead of focusing on one symptom alone? Welcome back to MSwired Podcast. I'm Selena, physician assistant navigating life with multiple sclerosis, chronic migraine, and chronic pain, and your host for real conversations about health, chronic illness, and resilience. Today's episode is an important one because we're diving into topics that are often misunderstood, overlooked, or misdiagnosed. Migraines, POTS and dysautonomia, hypermobility and Ehlers Danlos syndrome, and how these conditions can sometimes overlap with neurologic diseases like MS. Joining me today is Dr. Kaplan, a board-certified neurologist and pain management specialist with extensive expertise in the disorders of the brain, nerves, and pain systems. Dr. Kaplan serves as medical director of the New York Neurology Institute and has been involved in clinical trials and research involving migraine, Alzheimer's disease, epilepsy, Parkinson's disease, and other neurologic conditions. He completed his MD PhD at Columbia University College of Physicians and Surgeons and has published extensively in neurology and neurodegenerative disease research. Today, we're talking about complex neurologic cases, why some patients struggle for years before getting answers, and how important it is to look at the whole picture when symptoms don't fit neatly into one box. Dr. Kaplan, thank you so much for being here today. I'm really excited for this conversation.
Glad to be here.
Thank you. For people who may not be familiar with your work, can you tell us a little about your background in neurology and what led you to focus on complex neurologic and pain conditions?
Yes. So you've started doing this for me in your introduction. I'm coming from kind of like a science background. I did all my training at Columbia University. And my PhD actually focused on the most devastating condition of the nervous system, which is ALS, or motor neuron disease. It's a bad one. We're not going to be talking about it much today, but this is what's informing all of my practice now. I've been a basic scientist working out why nerves die and why disease is caused. And then during my residency training, I started treating patients, did a fellowship in neuromuscular diseases, and for various reasons, diseases of the autonomic nervous system, which kind of controls the way your body works. That's how the brain interacts with kind of the rest of your body. That was a big focus of my studies. And so when I started practicing at New York Neurology Associates, it's a private practice in New York City, this kind of became my focus. And so I've been doing this for the past 10 years. And in the middle of all of this, COVID hit. And we'll talk more about this, but COVID has triggered just an avalanche of neurological problems, a lot of which have to do with dysautonomia and headaches and MS. It just I was there on the front lines of that. I've created collaborations with a lot of immunologists and musculoskeletal doctors who work with EDS, who work with some of these more complex post-viral syndromes. And so together, we've been managing kind of a large population of patients kind of with these difficult conditions.
That's interesting. And when you say COVID, do you mean the pandemic and just access to care, or someone actually having the COVID virus?
So it's someone who has had COVID.
Okay.
Develops what we now call long haul COVID, post-COVID, but it's actually a number of things, obviously, a lot of which are neurological.
Okay.
We know. And it just so happened in 2020, 2021, COVID infected basically everybody. And so everybody at the same time started coming down with these conditions. They existed before COVID.
Yeah.
There's nothing necessarily specific about it. It's a post-viral syndrome, which can trigger a number of things, multiple things. But there was just so many patients desperately seeking care. And so I was able to kind of see them and learn from them in real time. We were learning things.
Right.
As we were going along.
Yeah, because I was diagnosed with MS in the middle of a COVID pandemic. That's why I asked.
Yes. And so the research then caught up. Now their studies are coming where, in more academic centers, the cases have been compiled, studied, and basically we're confirming things that we were kind of dealing with in real time. Back in the day.
Also suffer from chronic migraines. So I know that migraines are often minimized as just headaches, but they can be incredibly debilitating for patients. What are some signs and symptoms that migraines may be more complex than just a typical headache disorder?
Right. So this is a big one. There has been recently kind of just a reevaluation in the whole headache world of what a migraine is. I mean, people knew about it, of course, for many years, but this is really, it's now more taught in medical schools that it's never just a headache. It is a syndrome of the brain that the brain gets into. There's a prodrome phase, then there's an active phase, and then there's a postictal phase. But basically that syndrome affects pain. That's why you feel pain, you feel the headache, but it almost always affects what we call autonomic nervous system. It messes it up. There's many studies on many levels, different parts of the brain that light up on functional imaging. People can detect special peptides and hormones that the autonomic nerves release being all kind of out of whack during a migraine attack or before migraine attack. But basically, in a nutshell, in addition to pain, people very often feel dizzy. People feel tired. People can feel profound fatigue. People can have, obviously, nausea. That's one of the hallmarks of migraine,
Right.
but sometimes it's more than that. It's just kind of just gastrointestinal dysfunction. Sometimes it's diarrhea. Sometimes it's just kind of just this bloating feeling. We now know why this happens. There are some medications. There are exciting potential treatment options, but bottom line is migraines are almost never just a headache. The reason why people sometimes don't think about it is because headache can be pretty bad. And so even though there's fatigue and all these things going in the background, people focus on the headache.
Right.
And so, yes, sometimes it is just a headache, and then people don't really realize that, why am I feeling tired all the time? They don't make that connection.
Right. No, it's a lot. It's a big, complex autonomic nervous system phenomenon. But when patients feel like they've tried everything for migraine and medications aren't working, how do you approach those more difficult or refractory cases? I know there's so many new exciting medications. CGRPs have saved my life.
Oh my God, yes, for sure. We love CGRPs. I mean, that said, that they don't help everybody. And so
Right.
there's definitely need for new things, and new things are coming out. But that was a revolution in our field. And I started practicing before CGRPs came along. And so what a difference. It's
Yeah.
a pleasure, yeah, to work now. But basically, it is something that happens to chronic migraine. So chronic migraine is a situation where migraine attacks. It could be headaches, it could be dizzy, all those things happen frequently and many times a week. And that's a separate situation from more like episodic migraine, where you just get them here and there and there's a beginning and an end. In a chronic migraine, basically, there is no beginning or end. It just goes on and on and on. And because symptoms can vary, sometimes people feel one thing, sometimes it's a headache. So even though the headaches may be happening like 3 times a week, all the other symptoms, all the other kind of dysfunction may be a daily phenomenon. When this happens, typical medications that help migraine headaches, even the new CGRP agents, kind of no longer work. The reason for it, we think, is because migraines, have triggers. We'll talk about more later, but the main trigger for a migraine is actually the experience of pain. This kind of chemical, all these neurotransmitters that get released during a migraine attack that cause pain, feedback onto your brain and make it more likely to produce the next migraine. And then on it goes. And so, yes, there are definitely patients who are refractory. We see the longer they've been in pain, the longer they've been in migraine, the more refractory they can become. And so it becomes kind of overwhelming. And I've seen people who have tried like 6, 7 different medication and nothing works. And then they give up, basically. But the main mantra of my practice is, in a migraine, we never give up. You just never do that. And sometimes that's kind of like, that's all I want to accomplish in the first visit, is just making sure this message sinks. We never give up. There's science behind it. Unlike, for example, epilepsy, right, seizures, there are refractory seizures in the brain. And if you failed like 4 medications, there's almost zero chance the 5th one will work. That is
Right.
not the case in migraines ever, because the reasons for failure in the migraines are varied. Sometimes it's just you couldn't reach a high enough dose. Sometimes it just caused too many side effects, but there's always something that can be done. And so again, the main approach is, never give up.
Right. I like that.
After that, it is something where we have to kind of go through everything and decide, well, why did things fail? Is it because we just didn't do enough? Or maybe it is, not a migraine. Maybe there's something else going on.
Right.
So that's tricky. Usually we're able to help almost everybody with the new kind of and emerging treatments and the combination of treatments. I would say in my experience, 95% of
That's
people
amazing.
um, feel some improvement.
That's great. And I know you made me laugh because I always have to go through as a clinician and a patient. I always say, okay, did I sleep wrong? Is it cervicogenic? Did I wear my night guard? Did I
Right.
grind? Is it a migraine? Like how I have to
Yes.
kind of determine what it is before I know how to treat it. And with that being said, there's so many newer migraine treatments, infusions, the CGRP
Yes.
medications, nerve blocks, other therapies. How do you determine what's appropriate for different patients?
So um, there are many factors that are involved. I mean, definitely CGRPs are becoming the mainstay of treatments, are sometimes limited by like insurance coverage, of course.
Right. Are you seeing better coverage now that they recommend a first line for some?
So yeah, most importantly, Qlipta, which is
Yeah,
atogepant. It's a kind of like a workhorse now.
I know that well.
Yes, and it really has made a difference for a lot of people. A lot. That seems to be better covered now for sure. Some insurance plans don't even require you to kind of fail older medication,
Yeah.
things like that. So, but does it help everybody at all? Not at all. Not at all. And there are some potential side effects that make people stop. But yes, CGRP agents are almost always kind of are in part of treatment. Sometimes, even though it's not technically diagnostic, but sometimes they do provide just almost like a clue, like, oh, well, maybe this is a migraine. People come in, their stomach hurts, like it's just
Yeah.
abdominal pain. Abdominal migraines, they're very common in kids, but
Yeah.
adults, it's less frequently seen. But definitely, sometimes we say, just try an Nurtec. Let's see what happens.
Yeah. My other favorite.
Yes, another favorite. But again, does it help everyone? No, unfortunately not.
Right.
And so sometimes we go with the oldest new cutting edge things. There are like the newest ones I've tried. There's a new acute pain medication. It's really been approved only for kind of post-operative pain. It's like a non-opioid sodium channel blocker. It's called Jurnavsk. It's like a mouthful. But
I've heard of
basically
that.
something cutting edge for people where nothing has worked.
Right.
We try things and sometimes they work, sometimes they don't. And sometimes we go the other way. We go to kind of really old medications that really have fallen out of use. Sometimes we have to use very kind of heavy duty antidepressant medications for prevention if nothing else worked.
Do you use any low dose naltrexone in your practice?
Oh, yes, all the time.
Because that's been
So
a game changer for me as well.
for you, for the chronic,
Yeah, for
so
MS, for neuropathy, but
for
I've been
an
taking it for about 2 years now. Yeah.
So I guess we should mention this. So migraines, chronic migraines are again a condition of the brain. There's all these chemical changes that take place in waves from time to time. But there's also kind of like a phenomenon that's called chronic pain. There's a phenomenon called central sensitization, where your brain becomes sensitive to various stimuli, including pain. When you have a headache, sometimes your skin hurts and things like that. Like touching the skin, something that shouldn't be causing pain, is painful. Your
Right.
muscles become really tense. You get these trigger points and things like this. That happens because basically your brain is on fire and it's just become so hypersensitive to things. And so this is what kind of unites migraines and some of these other chronic pain conditions, which we'll talk about. So this joint hypermobility and neuropathy and of course MS. And
Right.
so some of these medications, so the low dose naltrexone that seemed to work, we're not exactly 100% sure how it works, but it seems to kind of just lower that sensitivity a bit or raise the threshold for the stimulus that's not supposed to be painful for you to perceive pain. That's how we think this low dose naltrexone works. And yes, we use it a lot, a lot.
Yeah. That's good to hear. And many people with chronic migraine also experience dizziness, fatigue, brain fog, GI symptoms, like you were saying.
Yeah.
At what point do you start thinking about dysautonomia or POTS as part of that picture?
Yes. So that becomes very tricky. So as I said, we can think of migraine as an autonomic disorder, almost like Some studies show about over 80% of people with migraines have autonomic symptoms. And about 50% of those are more like kind of like a POTS-like picture. So POTS is a type of problem with autonomic nervous system. It stands for postural orthostatic tachycardia syndrome. Basically, in a nutshell, what happens is when you are upright, your heart beats really fast. That's basically the descriptive term. But essentially, what happens is there was a problem with your body regulating the blood flow. When you stand, the gravity pulls the blood down into your legs. That happens always, but there's all these nerves and the blood vessels and your heart and your brain. There's this whole network that monitors that and regulates that. So it's about like 30% of your whole blood volume goes into your legs. So to bring it back out so that your brain has enough blood to kind of work is it's a big feat. It's not surprising that for a lot of people, if something goes wrong, if the nerves or the blood vessels or the brain that control this process, what happens is when you stand, the blood doesn't appropriately get delivered to your brain, to your gut, to your muscles, and you get a whole slew of symptoms: fatigue, dizziness, palpitations, stomach problems, and pain and headache, everything. So this is a common condition. It's very common in women and it's common in migraines. And so it's sometimes difficult to kind of disentangle those two. But I would say when I start really thinking about it is when the fatigue, when the dizziness, when the gastrointestinal issues don't really resolve after we're starting to treat migraines. So people come with chronic headaches. We put them on Qulipta, we put them on Botox, we put them on Topamax, etc., and they're feeling better, but the fatigue is still there. The dizziness is still there. And that's yes, when we start thinking about it.
So kind of looking a little further.
So yes, again, we don't give up. We don't
Right.
just, well, your headaches are better, we're done. We need to kind of explore this further. And yes, I would say in my experience, same as studies, more than 50% of the time, when something like this happens, when your headaches are better, but you're still feeling crappy, it ends up being POTS.
That's interesting. I'm glad you don't give up.
No.
And joint hypermobility and hypermobile Ehlers Danlos syndrome, they're increasingly discussed now in neurology spaces. What are some common symptoms or red flags that make you think about hypermobile EDS in a patient?
Right. So hypermobile EDS it's kind of like a vague term, but basically it refers to patients with this problems in their connective tissue. So it's not necessarily nerves or brain. The underlying problem is connective tissue, which is things like collagen and kind of this hyaluronic acid. This is basically the glue in our body that holds everything together. It's everywhere. It's in our skin and our muscles, around our nerves, in the ligaments and tendons, holding everything together. So in people with this condition, that glue is a little bit looser than it's supposed to be. And it's a spectrum. It varies. Sometimes people are just a little bit more flexible. And sometimes it's a serious problem. People dislocate their joints left
Right.
with minimal, extension or flexion. And it's a serious problem. Ehlers Danlos refers to, sometimes so that listeners are not confused, sometimes it refers to a much more serious condition where the connective tissue around blood vessels becomes really, really loose and people get all sorts of aneurysms. It's a serious genetic condition. Usually younger people develop it, around sometimes as babies, sometimes in adolescence. What we're talking about is this condition called hypermobile EDS, where initially you're just a little bit more flexible and that's it. And that's why for the longest time, it hasn't really even been thought of as a problem, as a symptom.
Right.
But then what happens to patients like this, for whatever reason, sometimes it is some sort of inflammatory reaction that happened to their body. So COVID being one of them, but any virus. Sometimes it's vaccination. Sometimes it's injury, like a concussion. Sometimes it actually can be just severe psychological stress or trauma. Triggers your immune system, and then it kind of decompensates this connective tissue, and just things go really wrong. And people develop all sorts of symptoms, a lot of which are neurological. People develop horrible headaches and migraines and dysautonomia. Most importantly, POTS. Again, this situation where The blood flow in your body is just dysregulated completely.
That's interesting. And I know you mentioned too that it's common in women. And I know I hear from a lot of times I did primary care for 10 years, and a lot of my women patients would say that they told me it was anxiety and, it's stress
Yes.
related. And why do you think conditions like these are so commonly overlooked or misunderstood?
So the anxiety is very important because anxiety is something that happens on top of
Right.
if you're
Everything
having,
else.
if you feel like, one day you were a dancer or an athlete and doing, really well, basically, this is unfortunately the story. Like college athlete, ballet dancer, and then you get flu and then everything just unravels.
Right.
That's what happens.
The perfect storm.
The perfect storm. You will develop anxiety. Of course you will.
Yeah, I got that too.
Yes. So it happens. There is anxiety. The issue is this autonomic nervous system. Part of it is adrenaline, basically. When you're anxious, when you're having a panic attack, adrenaline is in your body. It's this fight and flight reaction.
Right.
This is the same thing where some people develop with POTS, with EDS. There's too much adrenaline in their body, and it's almost impossible to distinguish
Yeah.
what is the chicken, what's the egg.
Right.
When you feel like you're dying and your heart racing at like 200 beats per minute, you will be anxious.
Yeah.
So on top of that, a lot of the basic kind of evaluation, the basic studies that primary care doctors do or emergency room is able to provide, a CAT scan, or basic blood work, everything is normal.
Right.
Everything is normal. You're passing out. You feel like you're dying. You have headache every day, 24/7, but your MRI is normal. MRI of the brain is normal. Hurts like hell.
Right.
You're anxious because your life has unraveled completely. People, busy they make this connection and you're dismissed.
Right.
It's a common story. I'm very heartened that recently there's more awareness thanks to kind of platforms like yours. And,
Yeah.
there is more awareness and patients now come to me saying, I think I might have this.
Right.
Then I confirm it,
That's
so
awesome.
I would say 5 years ago, it used to not happen.
Right. And like you said too, I'm board certified in lifestyle medicine. So a
Yeah.
lot of times it's what you're testing. We have patients who have a normal blood chemistry, their glucose is fine, their A1C is fine, and then we get a fasting insulin and it's through the roof.
Right.
So I think, like you said, it's what you're testing as well. With MS, it has established diagnostic criteria. We now
Right.
use McDonald's criteria, which was just updated. But there are also many conditions that mimic or overlap with MS symptoms. I personally know people who were initially thought to have MS, but later discovered to have Ehlers Danlos or another condition contributing to their symptoms. So can you talk about how the overlap between these conditions can sometimes complicate the diagnostic process? Like, I know MRIs of the brain can have spots on the brain for both EDS and MS. Like, does that come up a lot when you're looking into patients?
It definitely does. Yes. I have a few patients who have both conditions. And that is actually, that's one of the most challenging patients that
I
I
bet.
treat because the symptoms could be almost identical.
Right.
MS can cause autonomic dysfunction. That's not quite like POTS, but the symptoms are the same. The reasons, like the ultimate, like the pathophysiology of that is different. In MS, it's because there is actual kind of this plaque, the inflammation in the brain region. If it's close to this region called hypothalamus or brainstem, you would get
Right.
dysautonomia. Constipation is one of the most common symptoms in MS. Fatigue is almost 100% prevalent, right? Numbness, tingling, headaches, everything.
Right.
So, and then on the background, there's migraines, which are common in MS. I mean, they're common everywhere, but they seem to be more common in MS, definitely common in EDS. And migraine headaches produce spots on the brain.
Right.
And so this is where, yes, it becomes a big challenge. And neuroradiologists are involved and they're hedging sometimes.
Yeah.
Okay, well, you have 5 spots. They could be migraine, could be MS.
So for the patient who has MS and Ehlers Danlos, would you be doing like a spinal tap to be more
Yes.
definitive? Or
You
okay, so then you
Yeah.
could still use McDonald criteria as a guide, but you would do a spinal tap. And then
We do, yes.
How is Ehlers Danlos diagnosed?
So the Ehlers Danlos diagnosis, it doesn't have a true what we call biomarker. In the works, there have been some studies for potential blood test, but not there yet. But the way we diagnose, when we suspect that there is joint hypermobility, and again, that happens if, for example, people come in with migraine and nothing works, or MS, and we're putting people on treatments, which I'm sure your listeners know. There's many excellent treatments these
Right.
days, really keep the disease under control. And yet new symptoms emerge. We do the MRI, there's no new lesions, no evidence, like I'm sure you know this.
Right.
If there's contrast enhancement, meaning parts of the nervous system light up where there's
Right.
active inflammation, we don't see any of that. And yet there's new numbness, or all of a sudden a new constipation, things like that.
Right.
So we suspect joint hypermobility, and we use this thing called Batten scale. Basically, certain joints in our body are known to be not very flexible. The joints of our fingers, thumbs, elbows, and knees. And so it's a very easy kind of bedside test to just overstretch the joint and see there's a certain criteria. If it's above certain angle of excursion, that
Right.
hypermobile. And if you have enough of these, the likelihood of something, not just random joint being hypermobile for whatever reason, which can happen, but more like an underlying connective tissue disorder starts to emerge. There are supporting criteria, the skin being a little bit stretchier. There's little, again, skin tags and things like this on people's heels and things that we look for that give us the clues. But it's really based on that, based on history, based on just people being a little bit looser than
Right.
should be.
That's
There
interesting.
is another condition that runs together with all of this that requires, it's important to mention, and that is the mast cell activation syndrome, which is a big one in the neurology world and neurology symptoms, and including MS. It's a condition that I would say almost every person with hypermobility has. Whether it's causing symptoms is a different story, but they go together. We're not sure why, but this is a kind of like it's an immunology condition. It is pseudo-allergic phenomenon where these things called mast cells, which are involved in allergic reactions. If you have a food allergy, like a peanut allergy, you eat the peanut, there's a reaction, and then these mast cells release this thing called histamine, and then you get all bad things happening to you.
Right.
So these mast cells are spread throughout our body, everywhere. They're everywhere, in our gut, in our skin, everywhere. For whatever reason, we're not quite sure why. People with connective tissue problem, their mast cells, they are just prone to releasing histamine and other kind of these molecules at random sometimes, and sometimes triggered by things that they're not supposed to do anything. It could be anything you kind of put in your body, any foods, any medications, things like this.
Right.
And in the end, what happens is histamine gets released, and it can be released sometimes in your skin, sometimes in your brain, sometimes in your gut, sometimes around your blood vessels, and you can just get a myriad of symptoms. But essentially, a lot of them, again, cause worsening dysautonomia.
Right.
They can cause headaches. They can cause pain. They can cause numbness and tingling. And so, again, when I hear someone telling me, someone with established diagnosis of migraine, MS, etc., every time I take a new medication, I just feel horrible. It's just like every medicine I take, there is a reaction, no matter the dose, no matter what. This
That's
is a
interesting.
huge red flag for a mast cell. Or just multiple foods. Like I eat something and then I'm out, I'm fatigued, or I'm in pain all day long.
Right. And then it goes into like leaky gut and all of these things.
This is where we start thinking, this is where my kind of sensors go up, and we start exploring these things.
I like how you practice.
Yes. So the same thing in migraine, refractory case, a person has migraines, tried 10 different medications, none of them work. But in the end, and for some people, it turns out it's just they had mast cell activation, so they just couldn't take medication at
Right.
good enough dose, or they just didn't even have a chance to try. The medicine itself, and sometimes it's just what's inside the medicine, like the compounding agent, triggers your gut, it triggers the mast cells to release histamine, and then all hell breaks loose, and you're not treating anything and just making yourself worse.
It's interesting. And brain fog, fatigue, pain, sensory
huge.
symptoms, dizziness.
Yeah.
There's so many symptoms that can exist across multiple neurologic conditions. And also, it can be symptoms from medications we're giving to treat some of these
Yes.
conditions. So, how important is it for a clinician just to step back and look at the entire clinical picture like you do instead of focusing on one symptom alone?
So it's, yes, very important. That's just kind of the mantra. Basically, when something isn't working, you step back
Right. No, I love that.
before charging ahead. That's just what you have to do. And sometimes it is, we're busy, patients are busy. They may not necessarily want to come to you. There's frustrations, and when like the fifth thing doesn't work.
Right.
So it's both on the patient and on the physician to kind of, okay, let's step back. Let's not just
Right.
admit again, defeat that nothing is going to help. Let's step back. Let's try. So yes, super important.
I love that.
Sometimes challenging to do though. Sometimes,
Yeah.
I must
So,
say.
for someone listening who feels dismissed, unheard, or stuck, no answers, what would you want them to know about advocating for themselves and continuing to search for the right care team?
My message is do it. I mean, you just have to try and do it. I mean, we live in a new world now, in a new age. Um, AI, right, which is for now available to everybody for free.
Right.
Not quite, but
Which is good and bad.
so far, yeah. I mean, I have a feeling that's not going to be the case
Right.
forever. But for now, we're kind of in this brave new world. I can tell you that certain AI models give right answers. I mean, they really do.
Yeah.
Their answers are out there on AIs, on these types of programs. So I've seen a number of people who came to see me after doing their own research.
It's great. You have to
And
be your own advocate. We know
you
this.
have to be your own advocate. But nowadays, what's changed in the past few years is there's a lot of misinformation, yes, but the information is out there. And the AI, it's getting better and better.
Yeah.
In a way, sometimes, will probably replace some doctors for some people who don't have access.
Right. No, it's crazy.
But that's what's happening. It's going to happen. So people should take advantage of that. Yes.
Yeah.
And get answers. Of course, I'm not saying you should follow what the AI tells you, but if you get some sort of answer that hasn't been explored, you should explore it.
Right. No, yes, with a medical professional, yes.
With a
And
medical professional, of course.
yeah, no, of course. And what are some misconceptions about migraine you wish people understood?
I guess the number one is that it's a lot of people feel like they kind of own their migraines. It's my migraine. It's just my life. That's just kind of how I am. And it's just kind of something that is there and will not get better. But unfortunately, there are many conditions that are truly like this. We don't
Right.
have solutions for them. But for migraines, we do. It is
Yeah.
the number one most treatable neurological condition. I'm always very excited when people come with complex things like this.
Yeah.
And because migraines is something that I can help with almost always.
I love that. And I was going to say, how do stress, sleep, hormones, lifestyle factors influence neurologic conditions like MS, migraine, dysautonomia? Like I said, we practice lifestyle medicine, so
Yeah.
we're big on nutrition, sleep, food.
We all counsel for migraines, definitely. This has
Yeah.
been known for decades, for years, that this is affected. Again, it's a problem, it's a headache, but it's also this autonomic nervous system problem. Has to do with your brain controlling your inner workings of your body, everything. Homeostasis, hormonal balance,
Right.
fluid balance, vitamin balance, all of these things. So the trigger for migraine in general, you can think of it, there's 50,000 triggers and they're different for different people, but essentially it's kind of like it's imbalance. The trigger for migraine is imbalance.
I like that.
And like for hormones, that is the number one imbalance. It's not so estrogen, right? It's linked to migraine, 100%, definitely. But it's not just estrogen itself, it's the fluctuations of it.
Right.
Drop in estrogen is the classic example. The drop of estrogen prior to menstrual cycle is one of the most potent triggers for migraines. It's the fluctuation. It's the alteration, like deviation kind of from your mean in your body. It's the problem with hydration, too little hydration. Sometimes it's the very common trigger is if you go hungry,
Yeah.
like your blood sugar drops.
I noticed that
Or
one.
with spike, it's a migraine trigger.
Yeah.
So things like this, and it affects everything. So yes, paramount importance. Sleep, paramount of importance to every neurological problem.
Yeah.
Every single one. I mean, it's a whole other topic. Of course, it affects,
Everything, even mood. Look at small children who don't sleep.
yes, it affects dysautonomia. Dysautonomia affects sleep. It's a complex thing. Yes. So yes, we ask about sleep. Every single patient, every neurological patient, we always ask about sleep.
It's so important.
It's so important.
I'm glad you have such a well-rounded approach. I like it. And I wish you were closer to refer all my patients.
Oh
And
yeah, yes,
I
yes.
think something many people living with chronic illness struggle with is the power of beliefs and symptom distribution. Like once someone receives a diagnosis like MS, EDS, migraine, any chronic condition, it can become easy to automatically attribute every new symptom or limitation to that diagnosis. So, how much do you think mindset and these belief patterns influence the way patients experience their symptoms, recovery, and overall quality of life? I belong to a lot of MS groups as a patient, but as a clinician, it's hard because people will say something and then they're like, I think it's my MS. And I'm thinking, that's not your MS. Like, you should be seeing a GI doctor for that. You know what I mean? Like, at
Yeah.
what point do you think that like mindset beliefs and these things play a role for these patients who are attributing all of these other things that are easily correctable to their chronic condition?
Yeah, so it's a double-edged sword. Once you receive a diagnosis and you find the support groups, and it's tremendously validating, and it's a source of definitely inner strength, kind of to own your condition.
Right.
We see this all the time with everything. But in complex cases, yes, people just attribute everything to MS or migraine, because that's a little bit of a fallacy on the sometimes on the part of the doctor too.
Right.
If you're treating someone for migraine, we know like almost every symptom can be a migraine, but sometimes
Right.
it's not. Yes, it's not. You have to, yeah, be careful. But from a patient's perspective, I think on the whole, owning kind of your condition and kind of making it your own is a positive, I would say. It is, but it has led to certain things being missed. Yes, I
Yeah.
definitely had a patient. It's not a great story. A patient with a different condition, neuropathy, polyneuropathy, inflammatory polyneuropathy, CIDP it's called, and
Yeah.
being treated and doing reasonably well, and then started developing new symptoms, a little bit more weakness in the legs and things like this,
Mm.
and problem peeing. And then in the end, it was a kind of like a tumor in the spine on top of their CIDP.
Right.
Things like this, yes, and then it's not, they just kind of didn't even think to go see a doctor.
Right. No, and I think that I've seen LDN work great for CIDP as well. Do you use a
Yeah.
lot of
Yeah,
Yeah.
yeah. So see, again, that's the kind of like the challenging part of it. This condition, it was correctly diagnosed. People were
Right.
responding to treatment, but slowly some things were kind
Something
of
was
not
off.
right, and they were just saying, well, it's probably just my condition getting worse. And by the time they came and I examined them, and I saw, no, 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 it looks different.
Yeah. So it's important to, like we said, be your own advocate. If something is wrong, don't think it's your illness. Still mention it to your
Don't think it's
doctor.
weird. You have to, any new symptom,
Right.
they should be mentioned. That's why you're seeing a doctor.
Yeah. Even if you don't think it's
Yeah.
relevant, let them decide.
Look, that is I would say, the value of seeing kind of like a human doctor in our new age.
Right.
That.
No, it's true. And on the provider side, I always like to mention, like you mentioned, do you think there's also a risk of healthcare professionals automatically attributing new symptoms to a patient's
Yes.
existing condition and overlooking something, like we said, because we have to find a way to balance validating a chronic condition while still keeping our clinical open mind? Because I had a patient who had foot pain, and they're like, my rheumatologist said it was my RA. Well, it was not. It was a stress fracture. And if I had not done an x-ray
Exactly.
and found out that they do CrossFit, and I was just thinking, and the x-ray was fine, but then the CT scan showed a stress fracture, and they were just being told, oh, it's your rheumatoid. So I think it's important for clinicians as well.
Yes, and I mean, absolutely. This is kind of what distinguishes, like, a good one from not so good one. But
Right,
sometimes
right.
it's just it really depends on the how busy doctors are.
I know.
Your
Sad.
visit is like 8 minutes. It's challenging, but yes, definitely that is what I learned from my mentors and residencies, that the whole stepping back. If something is not making 100% sense,
Right.
do
Keep
that.
looking.
Keep
And
looking.
What excites you most about the future of neurology and personalized treatment approaches?
Oh, yeah. So, I mean, look, it's incredibly exciting being a neurologist now. When I was starting out, it's been a while, we really didn't have much. I would say the only medications we had to offer were like gabapentin,
Right,
Parkinson's medication, some seizure medicines. And was kind of almost it in terms of like what we could do in terms of treatment. And in the last 20 years, I mean, there's just an explosion of
yeah,
knowledge and medications and approaches, and frankly kind of like just our understanding what's happening here in the brain. It is incredibly complex, and the outlook is really positive that with AI models and just
right.
fast drug discovery and doing genetic testing, you will have personalized solution so that we wouldn't have to go in a migraine patient through like 10 trial and error drugs before we
Right.
find something.
Yeah, and do you use the octave test?
Yes, sometimes. I mean, in my experience, it's just not there yet specifically kind of
Yeah.
to inform me which drug to use. It's not there
Right,
yet.
right. No, we use it as I get it every year just kind of to compare to my previous year, and I like to make sure I stay low.
Yes,
But yeah, it's complement to any treatment.
exactly. And so it's not quite there ready to like for prime time to just combine these two
Right.
approaches, all these extensive tests and things like this. But I really feel like now this is where it's going. And I think we are going to get there.
Oh, it's
In
exciting.
If someone is listening out there, and I'm assuming, having problems, you're having so many symptoms. The main thing is the help is out there and it's becoming better and more accessible now in our new age. And so
Right.
be an advocate for yourself, do your own research, try to see someone that there are these networks. There is a EDS society website that lists provider in every state. And so they're rare, but they do exist. And so if you think you have something like this, POTS is a huge one, by the
Yeah.
way. There are home tests that you can do to confirm your diagnosis. Literally, I mean, it's called NASA Lean Test, NASA Lean. Look it up. There's a PDF. It's basically you just measure your blood pressure and heart rate at home and tells you how to do that and bring it to your doctor. I mean, it
Right.
will alert them that something they can maybe refer you to someone. So yeah, don't give up.
Good advice. Dr. Kaplan, thank you so much for joining me today and for sharing your expertise on such important and often misunderstood conditions. I think conversations like this are incredibly valuable because so many people living with chronic illnesses and navigating overlapping symptoms, delayed diagnoses, years of feeling unheard. It's so important to bring awareness to migraine, dysautonomia, hypermobility, and MS. It helps patients feel less alone and empowers them to ask better questions about their health. Like we said, being your own advocate. Remember that you know your body best. Keep advocating for yourself, keep asking questions, and don't be afraid to seek providers who truly listen and look at the whole picture like Dr. Kaplan and myself. I like to think I do too. But if you enjoyed this episode, make sure to subscribe, leave a review, and share it with someone who may benefit from this conversation. And you can follow along at MSwired Podcast and more conversations around brain health, chronic illness, resilience, and living well. And you guys have an Instagram as well. It's New York Neurologists. Thank you so much for doing this.
Of course.